Hello dear students in the fifth stage of Faculty of Medicine in Jaber bin Hayyan Medical University. Welcome to our last lecture about the GIT series, and it is about the hepatitis B virus infection and acute liver failure. This lecture will be presented in two parts. In the first part we will discuss in details the hepatitis B virus infection. But firstly we have to review the outlines of this part. Firstly, we will take introduction about the virus and its virology. Then we will discuss the epidemiology of the hepatitis B virus disease. Then we will know about the pathophysiology and pathogenesis of the viral disease. The clinical manifestation will be none. The diagnosis will be made. The treatment will be established, and the prevention and control of the disease will be planned. Firstly, we will talk about the hepatitis B virus infection as an introduction of the subject. Hepatitis B virus is one of the smallest viruses that infect the humans. It is a pro-oncogenic because it may lead to development of hepatocellular carcinoma. So it is a pro-oncogenic, non-cytotoxic, enveloped, circular, partially double-stranded DNA virus of the Hepadnaviridae family. It infects the liver and causes hepatocellular necrosis and inflammation. Hepatitis B virus disease, it is the most common cause of the viral hepatitis in the world. The hepatitis B virus infection can be either acute or chronic, and clinically it may range from asymptomatic infection to mild disease or severe, or it rarely may lead to fulminant hepatitis. The acute hepatitis due to hepatitis B virus infection is usually a self-limiting disease marked by acute inflammation and hepatocellular necrosis. And the case fatality rate of this disease is about 0.5 to 2%, if you remember that from the general table of all hepatotropic virus group. And in approximately about 2/3 of acute infection, there is no identifiable exposure source is evident. And in about 1/4 of those acutely infected, they become lifetime carrier of the virus. So, lifetime carrier of the virus, this means chronic hepatitis. So, how we can define the chronic hepatitis due to hepatitis B virus infection? It is defined as persistent hepatitis virus infection. This means the presence of detectable hepatitis B surface antigen in the blood or serum for more than 6 months, with or without associated active viral replication and evidence of hepatocellular injury and inflammation. You remember that the definition and the time limit between the acute and the chronic hepatitis is the duration of 6 months. So just the presence of hepatitis B surface antigen in the blood or serum of a patient with hepatitis, this made the definition or meet the definition of chronic hepatitis infection. Now, this statement say age is a key factor in determining the risk of chronic infection. What does this statement mean? Which is very important. We will know this by showing this figure. As you see here in this diagram, we have two lines. The interrupted one reflect the chronicity of the disease, and the continued one reflect the symptomatic disease. So about 90% of those acquire the infection since birth, they will be a chronic infection, and the likelihood of getting a chronic infection is decreased as the age of acquiring the acute infection is a progress until reaching the older children and adulthood. So once the patient acquires the infection since birth, 90% it will cause a chronic infection. While on the reverse, those acquire the infection since birth, most of them, they are asymptomatic. Then while those acquiring the infection later on in the life, they will develop symptoms, especially after the age of 4 years and more. So that's why we say key factor in determining the risk of chronic infection is the age. If the infection acquired during birth or later on. Now, what about the epidemiology of hepatitis B virus infection? Worldwide, about 2 billion people have evidence of past or present infection with hepatitis B virus, and about 350 million are chronic carriers of the virus. This means positive hepatitis B surface antigen, which means the definition of chronic infection. The vast majority of those acquire the infection in the perinatal period and during early childhood. The vast majority of infections appears at that time. Then the overall prevalence of chronic hepatitis B virus appear to be decreased in many parts of the world, and the cause it may be, yes, due to increase the immunization after introduction of the hepatitis B virus vaccine as a part of the program of immunization in many parts of the world. Most endemic regions to develop or to have the hepatitis B virus infection are Sub-Saharan Africa and East Asia. As much as 10% of adults are chronic carrier in that regions, and up to 45% of world population resides in these endemic areas. So that's why it's very important. Worldwide, it is estimated that around 650,000 people die each year from the complication of the chronic hepatitis B virus infection. So if you recognize the numbers of the people that have the infection and those who are chronic and those who are died from the complication of the disease and compare it with other viral diseases, you will see the difference. But we regard the hepatitis B virus infection as an endemic, is not epidemic or pandemic like what happened with COVID-19. This map shows the distribution, and you can see here they divided the world into 3 areas of high prevalence. About more than 10% of population develop the virus, and intermediate, about 2 to 7% of population, and fortunately Iraq is in this yellow zone, and that blue, which is below 2% of population. And what this mean? This means the prevalence of the hepatitis B virus and the immune state toward it also. Now we will talk about the route of transmissions of the hepatitis B virus infection. This picture summarizes it, but we will talk in details. We can divide the route of transmission of the hepatitis B virus into vertical and horizontal. And if we talk about the vertical firstly, so we mean the perinatal infection. That is the disease that may be acquired in utero or at the perinatal period. So about 90% of infected newborns acquire the infection perinatally during the time of the delivery, and 10% occurring in utero. And 90% of infected newborn develop a chronic hepatitis B virus infection. And this is the explanation of the statement that say the age is a key factor in determining the chronicity of the hepatitis B virus infection, because 90% of those infected newborn develop the chronic infection. And the risk of the perinatal infection is greatest, about 90%, when the mother contracts the hepatitis B virus infection in the third trimester, acutely infected during the third trimester. So you notice that 90%, this number repeated 3 times. That is 90% of the infected newborn by perinatal way, and 90% of them will develop the chronic infection, and 90% of them their mother infected acutely in the third trimester. Now we have the horizontal route, and firstly is exposure to contaminated blood. How we can exposure to it? Through the shared needles, needle sticks, skin piercing, tattoos, or of course sexual transmission. And the third way of transmission, which is also horizontal, is the transmission via blood products like the blood, whole blood, RBCs, platelet, or fresh frozen plasma, or other parts like cryoprecipitate. But this has been almost eliminated by donor screening and donor blood testing protocols. For example, in Iraq, since the beginning of the 2000 and beyond, we start to do the test for the serology about the hepatitis B virus disease, about the cytomegalovirus, and the HIV. So in this way, reduce the likelihood of, and of course the hepatitis C virus also. So we, but this way, decrease the likelihood of getting the transmission through this way. Now, what are the risk factors for exposure? Or in other words, who are more susceptible to contract the infection? Firstly is the pregnancy and childhood. And you have to know that it comprises about 50% of those 350 million individuals with a chronic hepatitis B virus. Wow! Half of those with chronic hepatitis comes from the pregnancy and childhood. This means the vertical or perinatal route of infection. Other risk factor is exposure to infectious materials. The infectious materials, it may be body fluids, not just the blood. So body fluids of hepatitis B virus carriers, those have the hepatitis B surface antigen positive, are highly contagious and regarded as a source of infection for unvaccinated person, and this reflects the importance of vaccination. The third risk factor is intravenous drug users, individuals with high risk of sexual behaviors, and health care workers also as risk factors. And finally, the immune compromised persons. Individuals and those for immune compromised persons, individuals with a history of multiple transfusions, blood transfusion I mean, for any reason like thalassemia, any hemolytic anemias, organ transplantation patients, or those on dialysis, especially the hemodialysis, they are at high risk for infection where the vaccination in those patients specifically is less effective. So high risk of exposure and effectiveness of the vaccination is low, making the problem more worse. Now we reach to the pathophysiology, but this picture again show the infected blood or body fluid as a transporter of the hepatitis B virus infection, and this comes from pregnancy and perinatal infections, or from contaminated blood, or from the piercing or tattooing or other ways to contract the contaminated or infected blood or body fluids. Now it's the time to talk about the pathophysiology and pathogenesis of the virus. And firstly, we have to see how does the virus appear under electron microscope, as you see here, and how is the model of the hepatitis B virus. And here you can see that the virus has a surface, and the surface contains three sizes of protein. We have the small size, and we have the medium or intermediate size, and we have the large surface protein. Then we have the envelope, that then we have the icosahedral core, which composed of capsid like in the hepatitis A virus, and inside it we have the nucleotide or the genome of the virus, which is a partially double-stranded DNA virus with a polymerase. So this picture shows more clearly the virus. Here's the surface with the three sizes of protein, surface protein. This is the large, and this is the small, and this is the intermediate. Then there is the envelope, and this is the capsid and the core, and here is the double-stranded DNA with polymerase chain, and of course this is a partially double-stranded. So now is the way to define the antigens of the virus. This is the surface of the virus, as we say, and this is the hepatitis B surface antigen, which is very important, and we will talk about it later on frequently. So what is hepatitis B surface antigen, or sometimes they call just surface antigen? It is a part of the lipid coat of the virus, and it has a central role of diagnosis of acute and the chronic hepatitis B. You remember we say just to have hepatitis B surface antigen positive in the blood or serum, this is mean the patient is a carrier of the hepatitis B virus or chronic state of the hepatitis infection. So this is the importance of the hepatitis B surface antigen. Now we will go deeply to the core. Here is the red color represent the core over the genome of the virus, and here is we have another antigen called the hepatitis B core antigen. And what is this? This is on the surface of the nucleocapsid core, and its expression on the hepatocyte surface induce the T cell response, and it has a role in destruction of infected cell. You remember, we say the hepatitis B virus is non-cytotoxic and it didn't cause direct necrosis of the hepatic cell, but the necrosis of the hepatic cell and the inflammation comes from the immune response of the body against it. So what induces the T cell response is the hepatitis B core antigen, and it has a role in destruction of infected cells by this way, of course. Then between the core and the surface we have the envelope, and we have the hepatitis B E antigen or envelope antigen, and this is, as we say, between the nucleocapsid, core and lipid envelope, and it is a marker of active replication in chronic hepatitis. So the importance of this antigen is in chronic hepatitis. If it's positive, it means the virus in active replication state. And we have the hepatitis B virus polymerase, which is like this, and this is responsible for the replication of the genome, transcription and replication of the genome of the virus, which is the partially double-stranded DNA. This virion of the virus, its size is about 42 nanometers, its diameter. So that's why they called the hepatitis B virus is one of the smallest virus that infect the human. Now we will see what the virus will do when it enters the hepatocyte. Here is the hepatitis B virus particle or virion enter the hepatocyte via the process called endocytosis. This is the entry. The viral nucleocapsid are uncoated. This is mean removal of the envelope and transported into, like this. This is just, here is the DNA and the virus core. This will transported into the nucleus, as you see here, where the viral DNA is transformed into covalently closed circular DNA called cccDNA, covalently closed circular DNA. This will, as you see here, this will initiate the process of replication through the process of what is called the reverse transcription. Here is the reverse transcription. The mature nucleocapsid are responsible for mediating the viral persistence and may be released to infect neighboring hepatocyte. So you can see here, this will lead the process of transcription to develop into mature nucleocapsid, and the mature nucleocapsid itself may recycling to infect or to affect the nucleus again, or to infect neighboring cells. It regain its envelope, then through the process of endocytosis to other cell, the process will be repeated. The liver injury may occur through the immune-mediated killing of the infected liver cells, as we will see here. So here is the uninfected hepatocyte. By infection, this will lead to activation of the immune response, and the activation of immune response will lead to inflammation and cell death, and, as we say, cell killing of the infected liver cell. Of course, the infected hepatocyte will lead to more production of hepatitis B virus infection and then reinfection. And if there is a co-infection or alcohol state in adult, it will worsen the process of inflammation and cell death and lead to the picture of the clinical manifestations of a clinical hepatitis. So again, I will say the pathogenesis and the clinical manifestation of hepatitis B infection are due to the interaction between the virus infection and the host immune system. So, immune response and the viral replication or its activity, it will cause tissue damage. And this may be affected by host and environmental factors like, as we say, co-infection or alcohol. Tissue damage. It will lead to, with time, to scarring and cirrhosis. Tissue damage, scarring, and cirrhosis will lead to evidence of disease or the clinical manifestations of the hepatitis B virus infection. Of course, cirrhosis may progress to hepatocellular carcinoma, and in this stage and beyond, it may lead to death or it may need transplantation, of course. Now we will talk about the clinical manifestations of the disease. I think you remember that the clinical manifestations, it may be non-specific like any other causes of viral hepatitis, and of course it will affect the GIT and causing non-specific symptoms. Firstly, if you remember the incubation period, it's about 45 to 160 days, which is very long and a broad range for incubation period. And most infants and young children are completely asymptomatic, and we saw that by the diagram showing that the symptomatology of the disease is increasing after the age of 4 years. But it is completely asymptomatic in newborns or infants that acquire the disease by the perinatal infection. So we say most infants and young children are completely asymptomatic, especially if the infection is acquired vertically. And older children, adolescents, and adults are more likely to have symptoms, as we say. And about 30 to 50% of children more than age of 5 years exhibiting symptoms. That's why they say after 4 or 5 years. And these symptoms may be non-specific like slight fever, malaise, fatigue, and mild gastrointestinal upset. And the visible jaundice, which is very important symptom, is usually the first significant finding of acute disease, with dark urine and a pale stool, of course, with decrease. So this is associated with decreased appetite and emesis. So the jaundice is very significant and the first significant finding of the disease. The jaundice present after viremia, which means the high viral load in the blood of the infected person, and after the hepatitis B surface antigenemia have peaked. The presence of hepatitis B surface antigen, we say it reflect or indicate the presence of the infection after reaching to the peak level. In this stage and beyond, hepatomegaly is frequently present. And fulminant hepatitis, although rare, but it can be seen in patients with acute hepatitis due to hepatitis B virus infection. And you remember that we say the clinical presentation of the disease comes from the immune-mediated response against the viral presence and replication. So the antigen-antibody complex may not just involve the signs and symptoms related to the viral and the hepatic inflammation, but it may even precede the appearance of the icterus and characterized by macular rash or urticaria or hives, thrombocytopenia and arthritis. And the hepatitis B virus infection more rarely may present as a glomerulonephritis or nephrotic syndrome, again from the immune complex. It may invade the kidney, not just the liver. So this picture will again summarize the manifestations from the losing the appetite, fever, dark urine and pale pulp, nausea and vomiting, pain in the right side of the abdomen, the right hypochondrial area, and joint pain, hives or urticaria, headache, weakness and fatigue, and of course jaundice. Now, how we can diagnose the hepatitis B virus infection? The diagnosis, of course, made on the history, and in history it's important to focus on the epidemiologic history, like drug use or medical manipulations. That means the questions will be directed toward the root of a transmission of the disease. And of course, the full examination of the patient and the detection of symptoms of hepatitis B is very important. Of course, we need lab investigation like complete blood count, biochemical tests, liver function tests, and hepatitis B virus DNA by PCR, and ultrasonography of the abdomen to show the affection of the liver, and of course analysis for the viral hepatitis markers, very important, or the serology. So the hepatitis B markers is the hepatitis B surface antigen and anti-hepatitis B surface antibody, anti-hepatitis B C or core antigen antibody, and especially the IgM, and the hepatitis B E antigen, which is the envelope antigen that reflect the replication, active replication of the virus. Now we will put an interpretation for the markers of the significance of the markers in the hepatitis B virus. So what is the significance of hepatitis B surface antigen? It indicates acutely or chronically infected person. While the antibody to hepatitis B surface antigen, it indicates resolution of hepatitis B virus infection or development of immunity after immunization. Hepatitis B E antigen, it indicates, as we say, the high viral replication and increased infectivity. The antibody to hepatitis B E antigen, it indicates either decreased viral reproduction and decreased infectivity. While the antibodies to hepatitis B core antigen, hepatitis B C antibodies, this is indicate acute, chronic, or resolved infection, and we have to differentiate between the hepatitis B C IgM and IgG antibodies. Now, in acute infection, what we expect to find in acute infection? Who knows? Firstly is the presence of hepatitis B surface antigen, because this is indicates the infection, of course, and the presence of anti-HBC IgM confirms the diagnosis. This is enough to confirm the diagnosis, because the IgM, it indicates the acute state of antibody against the hepatitis B core antigen. And you remember the importance of the core antigen. Yes, it is initiate or induce the T cell response and destruct the infected hepatocyte. Now, the recovery from acute infection is accompanied by hepatitis B surface antigen clearance and appearance of anti-hepatitis B surface antibody and anti-hepatitis B surface IgG. So, if your patient with acute infection is cured or recovered, this will lead to, of course, absolute clearance of the hepatitis B surface antigen, because its presence means the patient is carrier of the virus, and it should be followed by the appearance or accompanied by appearance of the, of course, anti-hepatitis B surface antibody and anti-HBC IgG antibody for the which its presence indicate or reflect the antibody state of a chronic state against the recovered acute infection. The positive anti-HBS and negative HBC IgG, this indicate post hepatitis B virus vaccination. So the vaccination against the hepatitis B virus, it necessitates presence of antibody against the hepatitis B surface antigen, but of course, because this is vaccination, not a live virus, so there is no IgG antibody against it. And in the acute infection, the alanine transaminase enzyme can be temporarily elevated as affection of the liver function, but it will resolve and return to normal level. While in a chronic infection, what we expect to see? Of course, presence of hepatitis B surface antigen for at least 6 months to say this is a chronic infection. And the positive hepatitis B surface antigen document the vertical transmission to newborns. So, this is mean in those that at the age of 6 months of life, and we found the hepatitis B surface antigen positive after 6 months, of course we should suspect that the route of transmission for those infants is by the vertical transmission when they were newborns, newly delivered and acquired the infection perinatally. In the chronic infection, the alanine transaminase level can be either periodically or consistently increase, and this reflects the impairment of liver function from the chronic inflammation and fibrosis. Serum albumin and prothrombin time and total serum bilirubin is important to check in patients with a chronic infection, and we may find the serum albumin to be decreased, prothrombin time to be increased, and of course the total serum bilirubin increase also. In patients with a chronic inflammation, liver biopsy is important and most useful to determine the degree of fibrosis and inflammation, not just the biochemical and the liver function test. And in those patients, the renal involvement must be suspected or may be suspected on the basis of urinary findings suggesting the glomerulonephritis or nephrotic syndrome. You remember we say the antigen antibody complex may invade the kidney, not just the liver. So now we have this table, and here is the interpretation of the serologic markers. So if all markers, this means the hepatitis B surface antigen and hepatitis B surface antibody and total hepatitis B C antibody and specifically IgM, all of are negative, so this is mean the patient do not have infection prior at the time, and no prior infection and not immune, so he is susceptible or prone to develop infection in the future. And if we found just the hepatitis B surface antibody is positive, this is mean the person you take the sample from him has immunity for the hepatitis B infection after the vaccination or after passive immunization with hepatitis B immunoglobulin. and this is differentiated according to the concentration of the hepatitis B surface antibody. But if the patient has hepatitis B surface antibody positive and total hepatitis B C antibody positive, this is mean the patient is immune after recovery from hepatitis B virus infection. So he is not now having the infection, recovered from the infection, and by the presence of the hepatitis B surface antibody and the total HBC antibody. But if the patient have hepatitis B surface antigen positive and total HBC antibody positive, or total HBC antibody IgM positive, this is mean acute infection. And if the patient has the hepatitis B surface antigen positive and the total HBC antibody positive, while other markers is negative, this means the patient is in a chronic infection. So, I will repeat it another way. Firstly, you have to detect your patient has hepatitis B virus infection or not. This is will determined by the presence of hepatitis B surface antigen. So now you have to know your patient has, if he has positive, it is an acute infection or chronic. This is by the presence of the IgM antibody toward the hepatitis B core antigen. If it is positive, this is mean your patient in acute state. And of course the time is important also, if it's more than 6 months or low. But if it is not known to you, or you are not sure about the duration, so the presence of IgM, hepatitis B surface, hepatitis B core antibody, differentiate between the chronic and acute infection. But what if the patient has negative hepatitis B surface antigen? He is of course free of the acute or chronic infection, but he may be non-immune or not with no prior infection, or just immune, or from the vaccination, or immune from the previous infection. Now this diagram is very important to show the time course of the acute hepatitis B virus infection with recovery. For the hepatitis B surface antigen, it starts to rise toward the end of the 4th week, peak at about the 10 week, then start to decline at the 24 week, which is mean before the duration of 6 months, because this means the recovery. While the IgM also start to increase, then peak at the 16 week, and they start to decrease about then finished or disappear at the 30 week. While for the total anti-HBC, it start to increase from the 8 week after exposure and reach to the steady state level and remain in this way for all the time. While for the chronic infection, or progressive from the acute to chronic infection, the hepatitis B surface antigen here start to increase since the 2nd week of the infection and remain positive all over the disease for many years. The same thing happened with the hepatitis B, anti-hepatitis B C antigen, total antibody, sorry. It start to increase from the 7th or 6th week and remain positive all over years, while the IgM, it will decrease. And here there is no anti-HBs antibody like what happened in acute. In acute infection after recovery, there will be a development of anti-hepatitis B surface antigen antibody. And of course the hepatitis B E antigen, which is reflect the replication, active replication of the virus, will be of short duration. Then there will be development of the antibody against the HBE. While in the chronic disease, the active replication of course will take a time more than 6 months, and then after time there may be antibody to hepatitis B E antigen. Now, what is the differential diagnosis of hepatitis B infection? Of course, hepatitis B A virus infection because of the similarity in the presentation. Hepatitis B C infection, of course, or Epstein-Barr virus infection. Drug-induced hepatitis, autoimmune hepatitis, Wilson disease, hemochromatosis, or what's called gestation alloimmune liver disease, non-alcoholic fatty liver disease, and alpha-1 antitrypsin deficiency. Now, what is the treatment of the acute hepatitis B virus infection? For treatment for acute and for chronic. For acute infection, supportive measures such as bed rest and a nutritious diet are used during the active symptomatic stage, and there is no specific treatment, and corticosteroids are contraindicated, and in complicated cases by acute liver failure, which is rare, the nucleoside or nucleotide therapy may be helpful, and sometimes liver transplantation is successful in acute liver failure due to hepatitis B virus infection. While in treatment of chronic hepatitis B virus infection, here is very important to put the plan of a treatment according to the phases of chronic disease. Actually, we have 3 phases of the disease, and the classification depend on the load of hepatitis B virus DNA by the PCR test and the liver enzyme alanine ALT, and according to the liver biopsy. So I will start with an inactive phase. That is when the viral load is less than 2000 international unit per milliliter, and the ALT is normal, and the liver histology is normal or mild inflammation. Here is there no need for treatment. And of course, in those patients, the hepatitis B E antigen is negative. Again, hepatitis B antigen reflect the active replication of the virus. While those who are immune tolerant, whereas the hepatitis B antigen positive, there is active replication. So the hepatitis B viral load of DNA in the PCR is very high, more than 200,000 international unit per mole. But in those patients, the ALT or liver enzyme is normal, and the liver histology show normal or mild inflammation and scan fibrosis. There is no rule for treatment, so that's why they called immune tolerant. Although the active replication and the high load of the virus, the liver function and the liver histology is normal or mildly affected. While in those who are called immune active, and here the hepatitis B E antigen may be positive or negative, but the hepatitis load is high and between 2000 up to, or usually more than 20,000 international unit per mole. But here this presence of DNA causing elevated liver enzyme, and by histopathology the inflammation seen and fibrosis with variable degrees. So here is the treatment is candidate. So the importance is the liver enzyme, the histology, and the viral load in PCR. So this is another way algorithm of the treatment. As we say in chronic hepatitis, depend on the hepatitis B virus DNA and liver enzyme. So if the hepatitis B DNA is normal or decreased and liver enzyme is normal, as I say, there is no treatment. But if the hepatitis B virus DNA is high and the liver enzyme is also high, so there is indication for treatment. But what if the hepatitis B virus DNA is high but the liver enzyme is normal? Here it's very important to consider the liver biopsy. So if there is a moderate or severe histologic disease, treatment is indicated. But if there is no or mild histologic diseases, no treatment. Here is the immune active, here is the immune inactive, and here is the immune tolerant. Toward the active. So what are the treatment of the immune active phases? Firstly, the alpha interferon, and this is for 4 to 6 months. Then orally administered the nucleoside analog therapy, and the successful response in treated children is about 25%. This is a very high ratio regarded. And these are lamivudine for those more than 2 years, adifovir or tenofovir for children more than 12 years old, and entecavir. And finally, talbivudine for those more than 16 years of age. And this figure shows the progression or the advance in treatment of hepatitis B virus infection, starting from interferon in 1957, then at the 1990 and the 1991 also it was just on the interferon, while the introduction of nucleoside, the orally administered antiviral entecavir, was the first to discovered in the 1998, then the talbivudine in 2001, and adifovir in 2002, and in 2005 entecavir, and the last one is the tenofovir in 2008. Now, how we can prevent the hepatitis B virus infection? Firstly is the vaccination. And you know the universal immunization of all infants born worldwide, and as I say, even in Iraq and since a long time, the hepatitis B virus vaccine given in the expanded program of immunization since birth. The first dose should be given as soon as possible after birth, and especially in the first 24 hours. And the delivery of the hepatitis B virus vaccine within 24 hours of birth is 90 to 95% effective in preventing the hepatitis B virus infection, as well as decrease the viral transmission if followed by at least 2 other doses. And the regime in Iraq is to give the hepatitis B virus vaccine at the first 24 hours, then given at 2 months and at 4 months. At 6 months. In 5 to 10% of vaccinated children, they have a poor response to vaccination and will remain susceptible as adults to acquisition of the hepatitis B virus infection. And why? This is because of the low immunogenicity of the hepatitis B vaccine, which contain only recombinant hepatitis B surface antigen. If you remember, the type of the hepatitis B vaccine, it's called the viral subunit. In this vaccine, they remove the core antigen and the envelope antigen, and they put just a part of the hepatitis B surface antigen in as a viral subunit. So this is regarded as low immunogenicity, and sometimes in 5 to 10%, it may yield a poor response to vaccination, and the patient may remain susceptible as adult for the infection. Now, this is given for all newborns. Now, what we will deal with newborn, a neonate born to hepatitis B surface antigen positive mother. In those newborns, we have to give both the passive and active immunization. The active immunization is the vaccine, and the passive is the hepatitis B immunoglobulin, and this should be given in the first 12 hours of life. And the combination, why we combine the immunoglobulin, specific immunoglobulin against the hepatitis B and the vaccine, because this combination will reduce the vertical transmission for 85 to 95%, and the course of routine active vaccination against hepatitis B virus is not altered among those newborn. So we have to give them doses by the 2 month and 6 months of age. And for post-exposure prophylaxis, if we expose to patient with hepatitis B vaccine, here is the hepatitis B virus vaccine alone, or to give with hepatitis B immunoglobulin, as possible as after exposure to the up to 7 days. Now the question is, we say about the vertical transmission for newborns. So what about the breastfeeding? Is it contraindicated? No, it's not contraindicated, although the virus is detectable in the milk of lactating women. All children, but especially those with chronic hepatitis B virus infection should vaccinated against hepatitis A virus vaccine, which is not available in our country. And other control method to prevent the spread of the infection is including the screening of the blood donors and pregnant women, use of properly sterilized needles and surgical equipments, avoidance of sexual contact with carriers, and vaccination of household contact, medical personnel, and those at high risk. To all these will limit or reduce the way of transmission and will perform the control methods. Now remember, the hepatitis B virus disease is vaccine preventable, and this is the first dose of vaccine that given in the first 24 hours of life, and this is that given in further doses at 2 and 6 months of age. Now what about the prognosis of the hepatitis B virus infection? This diagram will show that acute hepatitis B virus infection in 90% of the cases will get complete resolution, and in 1% of them there will be fulminant hepatic failure in the acute. But 9% of those with acute hepatitis B virus infection will develop chronic disease by the presence of hepatitis B surface antigen for more than 6 months. So although in those there is a 50% resolution, and it may be either asymptomatic carrier state or chronic persistent hepatitis with extrahepatic disease like glomerulonephritis and nephrotic syndrome, and or polyarteritis nodosa, and chronic active hepatitis that will lead to cirrhosis or hepatocellular carcinoma without liver transplantation. You can see here that about 65% of the acute infection, they are asymptomatic, and 100% of them will get the complete recovery. 35% of them are symptomatic, and those 90% of them of symptomatic acute hepatitis will get the recovery, and 1% will develop acute liver failure and may lead to death, and about 9% will have a chronic hepatitis. For those with a chronic hepatitis, 70 to 90% of them will be asymptomatic carrier, and those will get the resolution annually in a percentage of 2 to 6% to complete recovery, and just 1% of them will develop hepatocellular carcinoma, and 1 to 30% will develop chronic hepatitis and cirrhosis. Again, just to remember that acute infection may lead to chronic infection, which may lead to liver cirrhosis, liver cancer, and liver failure.